in the machine like that. But after that, what he will do? You have to give the prophylaxis. So that is called the secondary prophylaxis. And primary prophylaxis means you are just trying to prevent the pneumocystis jirovecii infection. So in that case, the common indications are when the CD4 cell count is less than 200, or CD4 percentage is less than 14, or there is fever for more than 3 days, that is PO, or there is associated candidal infection, or there is other AIDS defining disease, particularly Kaposi's sarcoma. So these are the conditions where you will give the primary prophylaxis. Actually, in our setup in West Bengal, we are giving the primary prophylaxis particularly on the CD4 cell count, that is those who are having the CD4 cell count less than 200, we have to give the primary prophylaxis by co-triamoxazole, one double strength, Bactrim DS or Septrin DS like that. Question is how long you will give, when you will discontinue, whether patient, that is the PLHA, patient living with HIV, they will continue lifelong for this co-triamoxazole prophylaxis? No. If the cell count, CD4 cell count more than 200 and the HIV viral load is negligible, that is undetectable, that is less than 50 copies, then for more than 3 months, then you should discontinue the prophylaxis, whether it is a primary, whether it is a secondary. So I have told that is the 90% of the cases of this respiratory disease due to infection. One is community acquired pneumonia, second is pneumocystis jirovecii, and third the tuberculosis. The pneumocystis jirovecii I have discussed in detail, including the signs, symptoms, diagnosis, treatment and prophylaxis. Regarding tuberculosis, 15% of all the new tuberculosis occur in HIV infected subjects. That means if we get 100 tuberculosis patient, new patients, 15% they will have the associated HIV infection. Those who are sitting in this auditorium, around 90% we have suffered from tuberculosis, we don't know. And all of them, the bacteria are healed or they are in a very dormant state. If there is a HIV infection, then this dormant state will come into the active phase. So, active tuberculosis occurs between 20 to 40 times more common, more frequently in the HIV infected subjects. Hence, it is a dictum that is all tuberculosis patients in our country, HIV should be excluded. And reverse is also true. That is, if the patient is suffering from HIV, we should exclude whether the patient is suffering from tuberculosis or not. So in both ways, it is important. More than 2/3 of the patients have a TB and HIV co-infection present in pulmonary disease. That is important, that how the tuberculosis will present in the HIV patients. It depends on the CD4 count. That means, what is your immunity? What is the basic difference between the children and the adult? In the children, it is a primary complex, primary progressive disease, where you will not get the capital lesions, where you will get the lymph node plus the pulmonary lesion. Whereas in case of adults, where the immunity is much more, you will get the capitalization. Typically, you will get the upper lobe infection. Same is true for these HIV patients. That means those who are having the CD4 count around 500. And number one, most important, HIV tuberculosis may occur at any CD4 level. That is very important. So, the patients who are having the 500 around CD4 cell count, they will be having the adult type of tuberculosis. And X-ray picture will show the upper lobe involvement and cavitary lesions. you may or may not get the sputum positivity and the bulb fluid smear positivity. When the CD4 cell count is around 200, 150, that is less than 200, then you will get the non-specific, patient will have a non-specific malaise, fatigue, weight loss, anorexia, mild cough like that. And X-ray picture will show the diffuse or miliary shadow. Lymphadenopathy either mediastinal or hilar, I will show it, or there will be pleural effusions. That will be in between 100 to 200 like that. And when the CD4 cell count is very low, that is less than 100 or 75 like that, then it will present just like the children. And it may occur in the lower zone or middle zone, and there may be disseminated infections, either the bone marrow or the meninges or the kidneys, or there will be hepatosplenomegaly. The very important is blood culture will be positive in this group of patients. Around 50% of the cases. 50% of the cases when the CD4 cell count is around 75 or 80 or 50, blood, if the patient is suffering from tuberculosis in the form of dissemination, blood culture will be positive around 50% of the patients. And several body sites or fluid culture will be positive around 50%. So culture will be positive if the CD4 cell count is less. This is very important slide. AFB smear, it is a presumptive diagnosis but not a definitive diagnosis. Please keep it in mind. In our country, when the smear is positive for AFB, we are giving the dots therapy, category 1, category 2, like that, category 4. But it is a presumptive diagnosis in case of HIV. The reason is, I have told you, the three important causes of respiratory infection, one is the bacterial, one is tubercular, one is pneumocystis jirovecii, 90% of the cases. At present, we are discussing the last one, that is the tuberculosis. In tuberculosis, not only the Mycobacterium tuberculosis, but Mycobacterium other than tuberculosis. So if the patient is suffering from the Mycobacterium other than tuberculosis, that is the Mycobacterium avium complex, in the sputum you will get the AFB. So it may be due to Mycobacterium tuberculosis, or it may be due to Mycobacterium avium complex. You don't know. Why there should be difference? Because the treatment difference is there. In case of Mycobacterium tuberculosis, you have to give the standard drugs. Whereas in case of MOT, that is the Mycobacterium avium complex, you have to give the clarithromycin, you have to give the rifabutin, you have to give the ethambutol. So the total treatment is different. So that's why you should do the culture. If the culture shows the patients were smear positive, you should do the culture. And culture, if it shows that it is a case of Mycobacterium tuberculosis, then you should give the ATT. Because in case of HIV patients, the lower respiratory tract, they may harbor this MOT, that is the Mycobacterium other than tuberculosis. So that's why in book it is written, there is demonstration of acid first bacilli on the sputum smear does not establish the diagnosis of Mycobacterium tuberculosis, since non-tuberculosis mycobacteria may colonize the airway and are increasingly recognized to cause the clinical illness in patients with underlying structural lung disease. Same is applicable in case of the gastric aspirate. That means if the gastric aspirate you are getting the AFB, definitely it shows that there is an infection with the mycobacteria. But which mycobacteria? Mycobacterium tuberculosis, Mycobacterium avium complex, particularly in HIV patients. So again here you have to do the culture. So this is the important last one. Already I have told. Positive blood culture for Mycobacterium tuberculosis are uncommon patients with normal CD4 cell counts. That is, the patient is around having 500 or 600 or 700. We will not get the blood culture for this AFB. But when the CD4 cell count is around 75 or 80, blood culture will be positive for AFB around 50% of it. So AFB smear, it is not a definitive diagnosis.
Culture at what time?
I will come, sir. I will come. Please. So AFB smear, it is, please keep it in mind that AFB smear, it is a presumptive diagnosis in case of HIV. But AFB culture is a definitive diagnosis. So definitive diagnosis depends on the recovery of mycobacterial tuberculosis from cultures or identifying of organisms by DNA or RNA amplification technique. So what Dr. Sengupta was asking, that by the backtick it will be around 7 to 10 days, but the latest one is the NAT, that is nucleic acid amplification test. It may be NAT TB or NAT R. NAT TB, that is the NAT. I am coming. Nucleic acid amplification test for tuberculosis. It will give the result within hours. Suppose the sputum you have got positive and you have got the every facilities, we will come to know whether it is a case of Mycobacterium tuberculosis or Mycobacterium avium complex. Within hours you will get. So that is the nucleic acid amplification test. That is a NAT-TB. And what is NAT-R? It is the resistance. Whether that tuberculous bacilli is resistant to INH or rifampicin or the first line of drugs. So that is called the NAT-R. So what is the relation between the AFB smear and NAT-TB? I have told you. One is the presumptive diagnosis and is the definitive diagnosis. So if the AFB is positive and NAT-TB is positive, that means you are sure that patient is suffering from this tuberculosis. To give the TB treatment as per the DOTS guideline, RNGCB guideline. If the AFB is negative, but you are having a suspicion in mind that patient is suffering, most probably suffering from tuberculosis, then you go for NAT-TB. And if it is positive more than 2 times, that is the more than 2 occasions, 3 occasions, then you give the treatment. If the AFB is negative, but you are having the suspicion of patient is suffering from tuberculosis, do the NAT-TB. If it is negative, you have a clinical judgment. That means you are thinking there is ATT on trial. You are not having any documentation, evidence, laboratory evidence, but you are highly suspicious because there is a contact history, month, who is plus minus like that. You can give after counseling. This is very important. Resistant tuberculosis. In case of HIV co-infection with tuberculosis, around 30%, 25 to 30% they have a drug-resistant tuberculosis. There are 4 types of drug-resistant tuberculosis. One is simple, that is patient is either resistant to INH or rifampicin. Second is MDR tuberculosis. What is that? The patient is resistant to both H and R, that is INH and rifampicin. Third is XTM, that is the extensive drug-resistant tuberculosis. What is that? Same, INH, rifampicin plus quinolones. That means ciprofloxacin, ofloxacin, levofloxacin plus one of the injectables. That means either streptomycin or amikacin or kanamycin or capreomycin. So 4 types of drugs, that is INH, rifampicin, quinolones, plus one of the injectables. So this is HTR tuberculosis. Prognosis is very bad, very bad. And what is polyresistant? Polyresistance means not fitting to any of the above C. That means suppose the patient is resistant to INH plus ethambutal plus ciprofloxacin, but not to the injectables or to the rifampicin or to the paracetamol, not fitting to the any group. So that is called the polyresistant. And this resistant tuberculosis is common in case of HIV co-infection. So in the developed countries, they are not only diagnosing the tuberculosis, but also from the very beginning, they are doing this resistant. That is a way that they are resistant to the first line drugs or not. TST means there is a tuberculin sensitive test, that is the MAN2 test. MAN2 test, if it is positive, in case of HIV, there is a cell-mediated immunity is low. So naturally, we expect that it will be negative, that is less than 10 millimeter in duration. But here the cutoff value is only 5. So if the patient is having the TST more than 5, if the patient is HIV positive, and then patient has at least there is some sort of dormant tuberculosis. Here you can give the HIV prophylaxis, INH prophylaxis for 9 to 12 months. You are not getting the telltale features of tuberculosis. That means you are not getting the sputum positivity or radiologically, but patient is having the weight loss, cough, night sweats, anorexia. So if the sputum is positive, you should give the INH prophylaxis, and also there is a history of contact in the family with the tuberculosis. You can give definitely 9 to 12 months INH prophylaxis. So treatment, DOTS, category 1 or category 2 as per situation, plus CART. At present, the heart is obsolete. That is highly active retroviral therapy, it is obsolete. In book it is written, it is CART, that is combined active retroviral therapy. Question is, when you will start, or which one you should start? Whether you should start simultaneously, DOTS plus CART, or CART first, DOT last, or reverse. The answer is, first you have to start the DOTS, and you have to wait for at least 2 weeks, and you have to start the CART within 8 weeks. That means 2 to 8 weeks. First you have to start the DOTS followed by CART. Previously, the opinion was within these 2 weeks, which one is important, whether early or late. Previously, they were telling that if the CD4 count is good, around 500 or 450 or 300, to shift the CART towards the later part, that is around 7 weeks or 8 weeks. But if the CD4 count is around 100 or 150, you start the CART as early as possible. That is around 3 weeks. But at present, the new guideline is that CART should be started as early as possible. So we can start the combined antiretroviral therapy around 3 weeks. But you have to give the DOTS first. And second important, if we are using the rifampicin, we cannot give the nevirapine. Instead of, we have to give the rifampicin. So that is important because there is a chance of drug-drug interaction between the rifampicin and nevirapine. That's why you have to give the rifampicin. So what is the problem with the early treatment of the CART? Problem is high pill burden. When you have to start this CART, you have to counsel the patient because most important is compliance. Usually patient will take 1 month or 2 months after that will fly. You will be total absentee. And if we give side by side this DOTS therapy, then you will be high pill burden. So that is the one important point. Drug-drug interaction I have already told. And overlapping toxicities, that is the neuropathy, particularly staburin and other drugs, they will cause the neuropathy, or it may be due to this ethambutol. So there is a overlapping toxicity, particularly neuropathy. Iris, I have discussed so many times in this platform, that is the immune reaction and inflammatory syndrome. Basically, when you are starting the cut, there will be CD4 cell count will increase. So naturally the patient's immunity will improve. And at that time, the patient may have chance for getting worse. So in the form of patient may have fever, patient may have vomiting, patient may have increased cough. So there are two parameters. One is whether it is a case of iris, that is the immune reaction inflammatory syndrome has occurred, or there is a treatment failure. So you should continue the cut. If the patient is very severe, deteriorating rapidly, then you have to give the steroid for the short course around 4 to 6 weeks. Another important is the LTBI, that is a latent tuberculous bacillus infection. Already I have discussed one important is that TST, that is the tuberculous skin testing, and second is blood ephedra, that is the another important thing, that is the interferon gamma assay. These two tests not for active tuberculosis, but for whether there is any latent tuberculosis. This is a typical picture of miliary tuberculosis. I have told the miliary tuberculosis will occur usually around 200, 250 or 150 CD4 cell count. Extensive bilateral tuberculosis, when the CD4 count is around 250 or 150 like that. Pleural effusion. Pneumothorax, right-sided pneumothorax, shifting of the mediastinum towards the left. Same, right-sided pneumothorax, and there is also some consolidation in the left lower jaw. This is mediastinal and paratracheal lymphadenopathy, along with the parenchymal lesions. Bilateral extensive tuberculosis. This is one of the important slogans. When a HIV virus and bacteria, tuberculosis can work so well together, why can't we? And at present, the RNTCP and NACO, they are working hand in hand. So we have this